Hey, good morning, good afternoon, everyone. Welcome to Breakout Session 3, which is Women Leading Across Borders. I'm Kate Dodson. I'm Vice President for Global Health at the UN Foundation and a board member of and avid cheerleader for Women in Global Health. I know several of you are migrating over from the main live stream on foreign policy, but we have such a rich discussion, such a packed discussion over the next hour that I wanted to make sure we could take full advantage of the time we have. So welcome those of you who are joining in a little bit late and really look forward to having your active participation in the conversation. It's already been an inspiring and thought-provoking morning so far, and I have the full expectation that we'll continue the same over the next hour. For this conversation on Breakout Session 3, Women Leading Across Borders, I'm joined by Winnie Byanyima, who is Executive Director of UNAIDS, Simelela, the Head of Gender and Sexual and Reproductive Health and Rights at the World Health Organization, Ferro, the Director of the Geneva Office for UNFPA, Rana, Hajjeh, Director of Program Management for WHO EMRO, the Regional Office for the Eastern Mediterranean, Flor Francisconi, Midwife and Board Member of the International Confederation of Midwives, and Françoise Vanni, Head of External Relations and Communications at the Global Fund. A reminder that this session is being recorded and will be available on demand at www.covid5050.org, so that you can come back to see the content if you have to leave during the live session or want to review the topics covered afterwards. And of course, you can also follow along on Twitter and add your voice to the conversation using the hashtag WGHSecuritySummit alongside hashtag COVID5050 and hashtag UNGA. And please tag Women in Global Health, Wagner Foundation, and the UN Foundation. Over the next hour, and I'll remind that we'll actually adjourn 10 minutes late, so on the East Coast, 12:10 p.m., 6:10 p.m. in Central European time. Over this next hour, and wishing, of course, we'd have more time, my role is to be a moderator to spark the conversation, but eager for our panelists to build on, debate, and engage with each other, and for those of you tuning in to join in the conversation too. You can use the Q&A function, please, on Zoom to ask questions. The chat is also open for dialogue and exchange and views, but those of you who want to ask a question to a panelist, please use the Q&A function. And please share your name and affiliation, if relevant, when you do. I anticipate this will be a rich discussion and we won't get to all the questions, but the beauty of this is that it presents great fodder for continuing the conversation at the beginning of the next session, one of our networking sessions. Over the course of this conversation in the chat function, you'll see links to the networking sessions, which will start at 12:10 Eastern, and I hope to see you there. Before we begin into a set of questions that I'll first ask to each of our panelists, I want to start with inviting Winnie Byanyima, the Executive Director of UNAIDS, to give us some framing comments on how diversity and leadership can yield more inclusive and equitable health systems. Over to you, Winnie.
Thank you. Thank you for having me on this really very distinguished and interesting panel. Let me share some statistics of where we are in the world today. In over 100 countries, laws exist that prevent women from working in certain jobs simply because they are women. Over 100 countries. 25 years since the Beijing conference on the rights of women, and I attended it in Beijing 25 years ago, the number of women parliamentarians, which is one of the main indicators of progress, has only grown from 17.8% to 24%. The needle has moved just 6%. Which means that it would take more than 100 years before we ever achieve equality of men and women in parliaments. In business this year, 13 women CEOs of the FTSE 350 companies, only 13 women CEOs out of 350, just 5% of company leaders. It just tells you the absence of women in leadership is huge across the world, whether in politics, in business, everywhere. But it's so important. Why is it so important? Because women, first, it's a human right. Women are more than about half the world. Their particular perspectives, their needs are the same as men's, but also different. And those perspectives and those needs must be served, must be listened to as a human right, but also as a factor for success of the world, whether economic success, social success, or business success. So the inclusion of women is a matter of human rights, but also a matter of economic success. The picture isn't always bleak. We see progress. We see commitment in leadership changing the numbers. At the UN, the Secretary General has pushed and achieved already gender parity in senior management. In my own work at UNAIDS, we are 11 UN agencies in a joint program on AIDS. Of the 11 co-sponsors, 5 are now led by women, so almost a half. UNESCO, UNICEF, UNFPA, UN Women, and UNODC. So you see progress where there's political leadership. Why it is so important to include different perspectives and get it right for everybody. Also, human rights. Now, in the health world, we are seeing, and we have learned from fighting HIV/AIDS, that if you don't put human rights at the center of a health system, you never get to address and end an epidemic. Human rights must be at the center. So much of the exclusion of people isn't because the science isn't there, the clinic isn't there. It is to do with the fact that the person who needs the health care, their particular needs, their rights are not realized when they enter that space. In my country, Uganda, every day, by the end of today, 17 women will die in childbirth. Now, the country has made a lot of progress in setting up maternity health centers. They are now there in every small sub-county. There is one. But still, the number of women giving birth in health centers is low. What has it got to do with women choosing not to go there because they don't want to feel humiliated? They are asked to bring X, Y, Z things they don't have. They are poor. They are put in situations where they are victims rather than heroes of motherhood. So they prefer to give birth at home. When there's a complication, they will die in childbirth because they are not attended to. These are the risks they take because there's a health system that is not guaranteeing their rights as human beings. So human rights must be at the center. Look at the HIV epidemic. Today, we have the epidemic rising mainly amongst marginalized groups, gay men, sex workers, transgender women, migrants, people who inject drugs. These are human beings, but who can't benefit from prevention of HIV treatments and treatments. They can't because when they come before health workers, they are discriminated. They are stigmatized. Some of them are criminalized in their countries. Gay sex is criminal in my own country. So if you're a criminal, how can you come forward to a health center? If there's stigma about your lifestyle, why would you come for health to seek health? So ending stigma, ending discrimination, putting human rights at the center of health systems is what will deliver for people. So that's a big lesson we have learned from our work fighting HIV. The same now with Corona. Look what has happened with coronavirus. Countries came quickly, particularly in our poor countries, to lockdown to prevent it coming through the borders. But in the lockdowns, the public measures that were put in place didn't take into account the particular needs, the inequalities that were already existing in society were worsened. Women who worked in markets, who feed families, who grow the food, who fetch water for the homes, suddenly found themselves locked in their homes, unable to find food, unable to fetch water, and yet they are supposed to wash hands 5 times, 10 times a day, unable to go to clinics to take the baby who's got a fever. All this because a team of men, perhaps at the top, has taken a decision that to prevent the virus spreading, everybody stays at home. No consideration of the different roles and needs of different people. So a lens of gender equality, a human rights lens, is critical in fighting pandemics and in building health systems. These are the major lessons we have learned, that you need the whole of society to be involved in fighting, in defending health, in protecting, in preventing disease, and you need the perspectives of women and of other groups that are on the margins to be part of the decisions. So leadership that's inclusive is key for health success. I'll stop there.
Thank you, Winnie. What great way to frame our conversation. And I do hope panelists build on those inspiring first comments. I see a clear way for Nono to be able to kind of engage in response to some of these challenges that have vexed not only the progress towards universal health coverage overall, but COVID response in particular, Winnie, that you laid out. And I know WHO has been keen to try to instill gender transformative leadership across both its COVID response and its larger work, consistent with the general program of work. Nono, can you talk a little bit about some of that progress, especially over the past 7 months in the context of pandemic response? What has WHO been trying to do to advance gender transformative leadership? And what remains still to be done?
Thank you. Thanks, Kate. And just thank you very much to Winnie, because the points that she raised, I just want to take one and expand a little bit on it, just to say the fight for equality, for women to be accepted, acknowledged, and respected as very important players in communities and society, dates back to the pre-World War I. You know, if you read the history of how women just fought to be given the right to vote, you can see that the world is yet to really contend and to embrace the important role of women in society across all aspects of the work that needs to get done. You know, in my view, if this doesn't change, we will not achieve the Sustainable Development Goals. So what have we tried to do as WHO? First and foremost, I think it's important to acknowledge that at the beginning of the response, the entire focus was a medical and a scientific focus, which was really appropriate for the institution to find out what this whole virus, this COVID pandemic is about, what the virus looks like, and to really get our scientific community jumping in there ahead of the curve. And I'm proud to say that with foresight, you know, I don't think that Dr. Tedros even imagined that having Soumya as the chief scientist in WHO would really propel the leadership of women so openly and so obviously to the world. So we're proud of the fact that he's really championed the leadership of women, with more than 60% of his senior staff consisting of women from all over the world. And you've always seen that in the pressers that WHO gives, you've got women speaking, we've got our chief lead expert, who's also a woman. But behind all of that, the lived experiences of women across all 6 regions of WHO has really started to shape some of the policy briefs that are coming out. I think people know we've produced so many policy briefs on how to address gender-based violence, on how to ensure services stay open, et cetera, et cetera. But unless those briefs come together in an integrated manner, they remain unresponsive to women's issues, because women don't live single issue lives. You all know that. So even if you have a brief on GBV, you've got to ensure that everything brings together the socioeconomic impacts that are likely to really impact on women. And you've asked, Kate, what could we do better? I think as UN agencies, all of us, including all of our partners who've put this very important conversation together, think about the knock-on effects that are really going to be big. At the moment, we're speaking about building back better. What does that mean for an ordinary woman in a village or in an informal settlement? We've got to get governments to understand that the building back better is not just about getting the health system to work or getting, the drugs to work or getting the vaccine to everybody. It's about really going back to the fundamentals. Why are the women and the most vulnerable still left out of the conversations, of the decisions that impact their lives? There's a reason in the beginning there was a lockdown, but right now, the voices of the communities are still not coming out as sharply as we would like to see them. And I think it's our job as women leaders in these very powerful fora to insist that the voices of the communities must be the ones that inform policy. The top-down approach is not going to work. And being here right now, back home in South Africa for a short while, I can see that impact. Just the lady who's helping my family to be safe, she needs to catch a taxi. She needs to, fend for her own children. She needs to do other things which the elite don't have to worry about. So if we don't, really address that fundamental economic difference and push women into these powerful positions, insist, and make those laws very responsive, we will be faced with a second pandemic and women will be worse off. And the whole world will be worse off because we will not have done the things we should have done hundreds of years ago. So I really am excited that we are having this conversation. We really must make sure that next year, when we speak about Beijing plus 26, we must not have forgotten what this pandemic has taught us. It may still be with us, but let's continue to make these important interventions and force our institutions to respond in ways that express the lived experiences of women that we know very well. Thank you very much.
No, thank you for that, and appreciate hearing both more about what WHO has done and really putting that at the heart. Let's make sure that this has community voice, agency, and engagement at the center of response. And I think that's a great segue over to Monica Ferro from UNFPA. Women and girls are at the heart of UNFPA's work. How have you seen women and girls impacted? Is what's happening at the global level, as Nono described, really positively or negatively impacting women and girls? And as you look at sexual and reproductive health and rights in particular, what more can and needs to be done to further mitigate the erosion of RHR progress, even just over the course of this pandemic? Monica.
Thank you, Kate. First, let me start by thanking the organizers for inviting UNFPA to sit in this amazing panel. I think that Winnie and Nono were brilliant. There's just a few details that I'm gonna try to add to what they already shared. And you are right, Kate. We really understood that this pandemic was gonna have a disproportionate impact on women and girls. And so as early as March, we released our first policy brief on how to protect sexual and reproductive health and rights and promote gender equality, what we call the gender lens to the COVID-19 response. And Natalia Cannon, our amazing executive director, she's been saying and repeating that she can sum up the impact of this pandemic in women and girls in a world. It's devastating. And she always says, there are many women in situations of desperation right now, and all this tallies up to devastating health and social consequences for that woman, that girl, that family, that community. And we have been particularly concerned with the skyrocketing of gender-based violence. As Natalia has been saying, she calls it a pandemic within the pandemic, and that's very much in our mind. And we've all seen that around the world, women are facing a very heightened risk due to the pandemic. And it's been clear that frontline health workers, and this morning I've heard often the numbers, 70% of health workers are women. They face a direct risk of illness from COVID-19, for instance, but also girls and women outside the health sector, they face serious risks. Those requiring sexual and reproductive health services, they may face anxiety about exposure to the virus while they seek care. They may even forego care entirely. And others, they have lost access to care altogether due to the movement restrictions and also to curbed health services. We also know, unfortunately, that many hospitals and health centers, they are reporting declines in the number of women and girls that receive critical sexual and reproductive health care, including antenatal services, safe delivery services, and family planning. So last April, in the end of April, we actually commissioned a report on the impact of the responses of the pandemic in some of our core issues. And we understood that the impact on women and girls could be catastrophic, as million more women and girls around the world, they risk violence at home, unwanted pregnancies, child marriages, and more as the pandemic rages. For instance, we calculated that 47 million women in developing countries may not have access to modern contraceptives, and that would lead to up to 7 million unwanted pregnancies. On total, we also forecasted that 31 million new cases of gender-based violence. And in the next decade, due to the disruption of the global programs on ending child marriage and ending FGM that UNFPA runs with UNICEF, we expect, unfortunately, to see 13 million child marriages and 2 million cases of female genital mutilation that could otherwise be averted. And it's not irrelevant also, it has been mentioned in the panels in the morning and now by our first speakers, that also a shortage of condoms and other contraceptives, they will have a huge impact on women and girls. And before the pandemic, as I was saying, we already had 230 million of women in developing countries who wanted to use modern contraceptives, but they didn't have access to it. And so a shortage of contraceptives could lead, as I was saying, to 7 million unwanted pregnancies, often with devastating consequences, an increase on unsafe abortions, and in the case of condoms, of course, a rise in sexually transmitted infections and HIV. I've mentioned GBV, but I really wanted to focus that it's also due to the fact that women cannot leave the house to report, that we really need the service. And I heard this morning, Maria Espinosa mentioning that safe houses, shelters, hotlines for victims of domestic violence have to be considered a priority. And I would be negligent if I didn't talk about humanitarian settings, and circumstances are even more worrisome in humanitarian settings. I remember Natalia Cannon also pointing out to the tens of millions of people that live in refugee camps, for whom the physical distancing practice are not an option, and also other groups who have been particularly impacted by this. And this, of course, leads to the final part of your question. I'm going to try to sum it up in 1 minute. Of course, that we are deeply concerned that women's sexual and reproductive health and rights are being sidelined as a result of some of the urgent focus on COVID-19 measures. As Nono was saying, this purely prioritization of all health responses to the response directly linked to COVID-19, of course, this will have an impact. And we also know that sexual reproductive health services, they can save lives, and this pandemic has severely disrupted access to it. It's also much harder to identify and respond to violence at home at times when women and girls need the services the most. And in short, this virus is making existing inequalities even worse. And at the same time, we see that in many instances, in many forums, there's a pushback against the prioritization of the services. And what we always say, what Natalia Cannon always says is, if there's a pushback, we need to push forward, especially for two reasons. First, because we know they save lives, and we know they empower women, and we know they are really game-changing for the women and girls, but for the society overall. And the last final message would be that no organization and no country can do this alone. So as we, as the global community, come together in solidarity to respond, but also to rebuild after the pandemic, we have here an amazing opportunity to lay the foundation for a more resilient, gender equality societies, more healthier and more prosperous for all. But that can only be done if we really acknowledge the leadership of women from the grassroots level up to local, regional, and global movements. And women's leadership and representation is non-negotiable.
Well, thank you for that. I'm glad you got to share that last thought in particular, but really rich insights, Monica. Thank you. You cited towards the beginning of your intervention this now oft-cited statistic about 70% of women are in the health workforce is 70% female, and in the social care sector, it's even higher. And I think the charge from your executive director to let's move forward on this is one that we should all think about, including in the female-dominated healthcare workforce, and make sure that they have the supplies, services, support, and rights that they're due. Rana, I wanted to ask you about that in particular, the impact of this pandemic on the healthcare workforce in the EMRO region. And as you think about charging forward, you know, what more can be done to help support their needs in particular?
Yes, good afternoon, good evening, good morning, colleagues here in our region. It's actually evening, but thank you very much for Women in Global Health for inviting me to this. And it's really very, very timely topic to discuss how can we best achieve gender responsive global health. Very thankful to my colleagues, to Winnie, to Nono, to Monica for all their comments. And I think this time, I mean, I've been part of many global emergencies over the last 20 years. And this is the first time I see such attention given to the gender issues so early in the pandemic. So, you know, I think it's a very good segue from what Monica was talking about with the emergency and the humanitarian situations to talk about our region, the Eastern Mediterranean. We have 22 countries. Out of the 22, 12 of them are actually in some form of emergency or humanitarian crisis. We have one of the largest in the world, actually the largest is in Yemen, but also we have Sudan, Somalia, Syria, Afghanistan, and many, many others. So we are used to dealing with gender issues and many other actually public health priority issues during emergencies. But what this pandemic has done, it has really made things much worse. And I think maybe to step back a little bit, it's fully understandable when you have major emergencies like this, that the first issue is survival. And some of these important areas, whether it's gender issues or some other really important issues in the way we approach global health, sometimes get delegated to a second place. So it's really, I think, all of the UN agencies for sure, but I think many other organizations this time alerted us, we all alerted the world very early on to the importance of dealing with the gender issues for various reasons, because women were directly affected and indirectly affected actually this time with COVID. And, you know, I just would like to bring attention to also an advocacy brief, kind of like a policy brief on gender and COVID-19 that was published by WHO. Also to, I think it's very useful because it's a really nice summary of all the issues. It was published in mid-May and it's on our website, and I won't repeat what Dr. Nono has said already, but we'll focus on issues in our region. So of course, the health sector in general overall is a major employer of women. Similarly in our region, you know, compared to other sectors of employment. And we have seen, even though our region has lagged behind in terms of proportion of health sector employments that are at higher levels or higher pay, but we have seen major improvement over the last 15 years in our region. We still, for example, see the discrepancy in proportion of, for example, physicians, you know, in our region, physicians make about 35%. The women physicians are 35% of the physician, of the health workforce, compared to the nursing workforce, where the majority are actually women. And this is where it became really important in the middle of this pandemic to look at this. So we did also look at the impact of the pandemic on reproductive health services, but we also looked at it on all essential health services. And, I would like to put it in perspective, because one of the things that one of the key services that are really important to women also are child services, immunization, some of these really key services that women care about, because women are usually the caretakers in their families, and all of these services got impacted. When we looked in our region on the impact of the pandemic, for example, on these services, we found that 92% of our countries reported that significant disruption in family planning and contraception. 85% of them reported disruption in the antenatal care, which of course places women at higher risk of dying from complications of pregnancy and childbirth. It's something we really don't want. Another issue that my colleagues mentioned, that during the lockdowns, of course, with everybody really and all the mental health issues, women were also at increased risk of gender-based violence during these lockdowns. And this was not just in our region, it was observed in our region, but also observed globally. We've seen very high numbers in Europe, for example, being reported. In terms of the impact on women in the health workforce in particular, they make up, like most regions, about 70% of the global health workforce in our region as well, and they are highly represented on the front lines, also among the frontline workers. We have, for example, let's say in Pakistan, where we have really taken advantage of our polio workforce. The women, in the field, 70% of all polio workers in the field are women. And many of these ladies, they call them lady health workers or women health workers. Many of them were actually repurposed in a way, or diverted to support our efforts in the field for prevention, contact tracing, and other activities. And we had many of them becoming infected, which is really, a huge sacrifice, in particular from women on our side. Another sacrifice I would like to mention, that in many of our countries, women healthcare workers often, in order or in fear of infecting their families, many of them would stay at the hospitals or the healthcare centers because they didn't want to go back to their families and put them at risk, which has also significantly, added the burden on them and the stress. So, what are we doing? What are we doing to bring attention to these issues and to ask our countries to do more in terms? So we, as I mentioned early on, starting in April, actually about 2 months into the pandemic response, we started first looking at the impact, to document it, to have the data needed to convince our policymakers that there are these issues they need to pay attention to. And we also developed operational guidance, in particular for all essential services, but reproductive and female health, women health issues took a lot of attention. And we disseminated this guidance very widely to our member states. We conducted a lot of training to also, most of it unfortunately had to be done online because we couldn't do this with the travel restrictions directly, but we did a lot of training in particular to healthcare workers, to women and men, but a large proportion of them were women, to ensure they are well protected. So, for example, infection prevention and control was one of the main areas where we put a lot of effort into training training healthcare workers, both at the primary healthcare centers as well as in hospitals, so that they protect themselves as well as their patients. And at our upcoming regional committee meeting, which is in about 2 to 3 weeks, we are going to also present specifically a paper again to all our ministers of health, stressing the importance of ensuring continuity of these essential health services that especially include women and their families, in particular like child health, because I think this is another area that has suffered significantly. It's of interest to all of us, all the women. And on top of that, I want to mention part of the essential health services that are relevant to many women in our region are the services, for example, related to chronic diseases, whether they are communicable diseases like HIV and TB, where we have some countries where also women are disproportionately affected, or non-communicable diseases such as diabetes and heart disease and others, where also women need to have access to these essential services and medications in particular. And last but not least, I just wanted to make a quick comment. I found when I was preparing for this a very interesting paper. There was a question of whether countries that are led by women fared better during the COVID response than other countries, because there were observations, for example, from New Zealand and others. And there was an interesting paper in the Journal of Health and Social Sciences by Sumik Purkayatsa, where they actually looked at a couple of indicators such as the reproductive rate and the proportion of testing. And even though they didn't find significance, statistical significance, but they found a positive trend in these countries that are led by women that did relatively better than the ones led by men. I thought this was interesting to report. But so again, again, this is probably on the same point that my colleague also ended previously hers. I think women leadership during this pandemic and women full engagement have proven extremely essential to us better controlling COVID in our region and globally as well. Thank you.
Thanks, Rana. And I think that point about leadership and decision-making is one that I would love to build on as we move to Flor Francisconi, who is a midwife and board member of the International Confederation of Midwives and is the ICM, International Confederation of Midwives, regional representative to COVID-19 response in Latin America. As a midwife, how has your experience affected your ability to make decisions as part of that work on COVID response in Latin America? As Rana pointed out, there's a dearth of female leaders making decisions on COVID. What has been your experience in that context around decision making for COVID response? And maybe even to pull a bit from the chat, has that experience been affected by a dominance of men in many of the rooms around COVID decision making? So Flor, look forward to your thoughts.
Yes, thank you very much for the question, and thank you very much for the invitation. It is an honor for me, a huge honor to be able to join you in this session as the International Confederation of Midwives Regional Representative for Latin America, and a confederation that currently represents more than 1 million midwives, 143 associations, and 124 countries. So coming back to the question as for my contribution, it is necessary to clarify first that the entire region, the entire Latin American region, has been very, very active and with a broad predisposition to joint work. So the support for the activities has been really very easy for me on a very solid ground, I have to say. We have worked since the very beginning of the pandemic with our partners such as UNFPA or PAHO in the region, with a strict monitoring of the organized response in sexual and reproductive health issues, and of course of the midwives who provide health services in the first line of action. At first, I have to say that it was not easy to make visible the work done mainly by women and for women, as we midwives do. So this main issue that you mentioned at the ICM have just one male midwife. We are mostly all women working for women. So to make them, women and adolescents, a priority for government in the redistribution of resources, as COVID demanded and still demands us to do, and also for midwives to be considered as frontline professionals who also deserve to be more politically involved in decision making. Even though this year, as you may already know, is the International Year of the Nurse and the Midwife, making visible and strengthening our work has been quite a difficult task, which is why, for example, we have even had to make a UNAIDS regionally declaration of the midwifery associations with the support, of course, of ICM to be disseminated among national governments, and also it is translated into English, so you can find it in the ICM webpage with other COVID-19 resources to make clear that we are frontline workers. For example, we've been struggling with the personal protective equipment because we were not considered as frontline workers. Another fundamental point was the alliance with women at a local level to achieve quality of care and attention, respecting the sexual and reproductive rights as human rights and above any pandemic. This has to be very clear. And this is why the organized response has included not only, for example, telemedicine service, but also traceability with the field and phone calls follow-up. In addition to a very strong commitment from the midwives and from the member associations of the Confederation for education and continuous training of the personnel to be able to give the best possible response to this catastrophe. All this, of course, in the context where midwives have been and are still struggling to support in their countries the pillars of the ICM in terms, for example, of updated regulation. This is needed to offer quality care for women, strong associations, and of course, education. We should also see that although this pandemic is a health catastrophe, because it is, we can capitalize it as an opportunity to unite midwives and women and ensure that our voices together are loud enough to be heard. And this is where I want to highlight your work and your commitment, the commitment of global in women in global health. And from my side, a last key message, and taking up the number of midwives that the Confederation represents. Just imagine that each midwife aligns with a woman who would be listening to the voices of 2 million women with a single message. So this is very powerful, and I really think that this is the way we have to do. Thank you very much.
Thank you, Flor. Really important thoughts there. And both you and others have talked about this concept of how do we make sure that as we move through and see the other side of this pandemic, we're doing it with a lens of building back better, more inclusively. We've learned the lessons and we're trying to help correct for injustices and failures in health systems. We have already also talked about, Monica highlighted a lot in particular, the impact of this pandemic on access to essential health services and on health outcomes. Françoise, at the Global Fund, I know you all are acutely concerned about that. But I also know that you are taking a longer view and trying to think about, are there ways that we can build back better to support particularly hardest to reach women and girls? How do you see this pandemic impacting trends in global health service delivery, in global health equity, and how can we make sure that going forward we are reaching those hardest to reach women and girls going forward. Françoise.
Thank you very much. Good afternoon, good morning, everyone. Thank you very much for the invitation and for such an inspiring panel. I'm very, very pleased to be here. So we, as the Global Fund, we are, as all of you have already expressed on this panel, extremely concerned about the potential for the COVID-19 pandemic to literally wipe out 2 decades of progress in the fight against the 3 pandemics, HIV, TB, and malaria, but more broadly in terms of the progress achieved in global health and also progress achieved in terms of gender equity and human rights more generally. So we very much share this sense of alarm of everything that is currently at stake. So just to give you an idea, perhaps, across the 3 diseases, the projections are telling us that literally we could go backwards by 10 to 20 years, depending on which of the 3 epidemics you look at, as a result of the direct, but most importantly, the knock-on effect of COVID-19. So it's really massive in terms of what it could undo after all those years of fighting and you know, pushing forward, as Monica said. So it's really concerning, sort of overall in terms of the SDG 3 and the broader SDG agenda, including obviously gender equality. We are concerned. So what we are doing at the moment is a few things. So first of all, we are monitoring very closely what is going on in countries, as many colleagues have mentioned, and we see a huge disruption in the programs that we are supporting alongside our partners across more than 100 countries. We see that about 3/4 of our programs are disrupted, whether moderately or highly or severely. So that's a huge disruption. And obviously, the most difficult programs towards the most marginalized and the hardest to reach population are the ones that end up being affected more severely. So we see, for example, that prevention, HIV prevention programs are heavily affected, right? Because obviously these are programs that go to key populations, stigmatized population, as Winnie said at the beginning, criminalized populations, and normally the best way to access and engage those vulnerable populations is through communities and door-to-door, and this sort of engagement that with the lockdown in many countries has not been possible at all. So in a way, the most marginalized, so women and girls, are heavily affected by HIV, as I'm sure you're all aware. This is really a terrifying trend that we see with around 1,000 adolescent girls and young women contracting HIV per day. This is per day, and this is before COVID. So prevention services highly disrupted, also access to treatment disrupted, because obviously you don't want to go to the health center, or perhaps you would like to go, but you can't go. Or perhaps you are asked questions that you feel really uncomfortable answering. You don't want to disclose your status, and so on and so forth. And also the fact that as part of the knock-on effect on the pandemic, so not the pandemic itself, but its implications, in particular in terms of access to education, this is also likely to end up with very significant and negative impact on young women and girls and their vulnerability to HIV. And we know that from facts, because we've been investing and focusing our efforts very much in prevention of HIV infections among adolescent girls and young women. And we know that the longer they stay at school, the most protected they are, or the less vulnerable they are to contracting HIV. So with schools being closed and young girls being the most likely to not going back to school, then we know that HIV infections are likely to go up again in this population. So monitoring and identifying those particular effects on the most vulnerable, as you said, so women and girls, but also more broadly vulnerable and key populations to HIV and the other diseases. So that's one, but listening. So we're doing, it's very difficult, of course, because the only way to engage at the moment is through these sort of screens, but we're organizing all sorts of communication channels, as colleagues have also referred to make sure that we listen and we document exactly the way that those populations, and including women and girls, are experiencing barriers, so that we can shape the programs and transform and adapt the programs that we are currently funding to address those sort of new challenges. And I think this feedback loop is what colleagues have been referring to as well, making sure that we know exactly how COVID is affecting the populations we serve, and make sure that as quickly as possible we adapt the way we program, the way we support, and the way we also advocate, obviously, with different partners at country level, to make sure that it is taken into account as much as possible. So that is super important. We are working with partners to try and protect the progress achieved so far, fight COVID-19, protect health workers, and we've heard already how many women are on the front line in different countries, and making sure that the voices of the communities most affected not only are heard, but help shape the response in a way that is inclusive, gender responsive, and hopefully to help the recovery to take us to, I don't know if we can build back better, but I hope we can. Let's push forward to build back better. That's certainly our commitment. I stop here. Thank you.
Great, Françoise. Thank you so much. I want to remind that we're going to take 10 extra minutes with the grace of the organizers at Women in Global Health to make sure that we get to a set of open questions from audience members before we turn over to the networking session. A reminder, the networking sessions, you'll find chat links soon in the chat function. You'll find links to those networking sessions in the chat function very shortly that you can hop over to at 12:10 p.m. Eastern, so in about 9 minutes. But in the meantime, that does give us the chance to ask a few questions that have come up via the Q&A function. A reminder, others can add their questions in there. I have seen a couple come in through the chat function as well. And I want to first ask the question that Ishigo asks. She's in private practice in Silver Spring, Maryland, and she asks a specific question about the mistreatment of women in detention, including forced hysterectomies that has recently been in the news. I want to perhaps ask, if panelists want to speak to that in particular, or just more generally. Others have talked about the rise in female genital mutilation and other gender-based violence. Are there aspects, or there strategies to hold governments and other stakeholders to account that you all are seeing or participating in that can really get to this most acutely vulnerable population of women who are being severely mistreated and whose rights are being severely impinged? Anyone want to speak about what they're seeing as kind of effective strategies on that, or what they're doing in particular around this issue?
Okay, Kate, can I respond?
No, that would be great. Thank you.
Great. I'll tie a few other issues that I've seen coming through the chat to this question because they are related. But just to highlight that within the UN system, there is a sustainable development group with a specific focus on ensuring that human rights-based approaches are strengthened, and ensuring that there are mechanisms that support member states to strengthen their ability to hold themselves accountable and to be held accountable for any breaches of human rights in the response to COVID. So that task team is working very hard with the resident coordinators, with the UN task teams on the ground to help countries, parliamentarians, civil society, and everybody to really sharpen that spotlight on abuse of people, communities, individuals across the spectrum of the COVID response. I think we will have a special report by the Human Rights Council, specifically as tasked by the UN Secretary General. And we will see a repeat of some abuses, I think, coming forth sharply. So I think we should be watching this space very, very critically. And just to answer two other quick questions that were asked that I think WHO can really add value to is indeed we are working with regional institutions across the entire globe, the AU specifically, and many others across the other regions. We're working with collaborating centers, researchers across the world. And I would imagine this is probably a first for the globe to see so much collaboration, so much solidarity in spite of the pushback and a lot of the other issues that are coming through from different parts of the world. The world is holding together, as it were, in spite of these challenges. In terms of other things that we need to collectively fight for and insist on is the building back or the re-strengthening of health systems should enable countries to make preparedness part of the primary healthcare system. Because I think the approach that we've taken is you've got the international health regulations and there's a whole concept and a way of doing things that sort of makes a pandemic a threat that is out there that we hopefully thought would never happen in our lifetime. And then there's a whole agenda around UHC that was not building the bridge between the two. So one of the things that WHO is doing very strongly is to show and to guide member states on making preparedness for the pandemic part of your primary healthcare system. That will require more training, that will require an investment, but it's better than the back foot that the world found us on. And I think people have seen the report that's come from the Global Monitoring Board of a world that was totally unprepared for this kind of pandemic. So I think we hopefully will learn more lessons. And as part of all this, what I'm noticing is that many of the things that impact on women should have been considered essential health services from the outset, and I think we missed that boat, and we should make the call, continue to insist that for women in rural parts of the world and everywhere, access to menstrual health care, services for reproductive health care, everything that impacts on their life is actually essential, because without it, women don't thrive. So I think if we can move from the siloed vertical approaches that are really standard for the UN in many of our work, we should really, benefit much more by doing exactly what we're doing right now. And thanks to you for bringing us together to start making those links with other agencies about how to really strengthen a comprehensive, coordinated response. And one last point I think you should all help us on is to urge member states to disaggregate data, report on disaggregated data, not just for the COVID, because the knock-on effects are going to be prolonged. People who've been exposed and are alive seem to be suffering a lot of morbidity, and who's going to care for them? Women. So we have to really insist and really make it a primary mandate that disaggregated data must come through, so we can at least rebuild policies that are more responsive than what we've seen. And thank you very much for this very exciting and affirming conversation. Thank you, Kate.
Thank you. No, and here. Those are great recommendations for how we can walk our talk more systematically going forward. Monica or anyone, I don't know if you had a burning thought on this question. Please.
Just a small footnote to what Nono was saying. Of course, that we've all understood that no organization can do this alone. And so it's really exciting to see the UN coming together. And even yesterday, I was seeing the president of the European Commission, and she was very clear. We need to strengthen multilateralism by design, not by destruction. So I think this has made very clear. This is why the UN was created. This is why the UN is a family. And this is also why we need to work together. As Nono was saying, data, one of the things we did in Moldova was especially create an online dashboard, because we keep on talking about the communities who've been most impacted, but we need quick mapping. Who are they? Where are they? So that we can actually reach out to them. And that was one of the key points. But my main messages would be we have to work together, because otherwise we will perish together. So I think it's not being dramatic, it's really acknowledging. And for that, women's leadership also brings extra points to the agenda and extra leadership. Thank you.
It's a great way, I think, to conclude our panel. I want to, before I thank our panelists, I want to note the kind of inspiring live art that's been going on our screen. Hopefully you've all seen it. I'm sure it will be circulated after, but I just always admire people who can really distill complex conversations and topics into something that feels visually, you know, poignant and coherent. So thank you to Josh and the team working on that. Thank you to all of our panelists for your remarkable leadership that you're walking and talking and speaking and engaging in every day. Thank you for your interventions over the course of this past hour. It's been inspiring to learn from you all. Just a reminder, in the chat function, you can see your networking links now. There are 2 networking sessions. First is on movements and their allies, how donors can support grassroots change and health. There's a Zoom link for that one. And the second networking session is on artists, activism and advocacy in global health security. What a great title. Zoom link is in the chat for that one as well. Those will stay open for a while. You can also see those on the Foreign Policy main page too. Thank you again to all of you. Thanks to everyone for tuning in over the course of this conversation. Again, also look at covid5050.org for the latest report, which includes a lot of the facts and figures that many of you have cited in this conversation. And I wish you all a great networking session. Thanks, everyone.
Great.
Thank you.
Thank you very much.
Everyone.
Bye-bye. Thank you.